Welcome, everyone. Today, we're diving into hepatocellular carcinoma, or HCC. We'll be focusing specifically on the essential toolkit you need for managing it effectively. It's a really important topic.
It absolutely is. And, managing HCC presents this unique challenge. It's not just fighting the cancer itself.
Right.
You're also dealing with the underlying liver disease, which is often, well, pretty significant. Think about it like trying to fix a leaky pipe while the whole house's foundation is shaky.
That's a great analogy. It really hits home that dual challenge. You've got the tumor, yes, but also this often very sick liver it's living in.
Exactly. And that's why standard staging, like just using TNM, often falls short for HCC. It doesn't capture that whole picture, especially the liver function aspect.
Okay, so for our session today, let's lay out the plan. We'll start with the crucial staging systems, how we figure out where the patient stands. Then we'll look at interventional radiology techniques, the different local regional options. And finally, we'll cover the latest in systemic therapy, which has really evolved quite a bit recently.
Sounds like a solid plan. So maybe we should start by digging a bit deeper into that idea of the two fronts in HCC. Why is the liver's health such a big deal here?
Yeah, let's do that. Explain why it's not just about the tumor specs.
Well, the liver isn't just a bystander organ where the tumor happens to be. In most HCC cases, the liver itself is already damaged, usually from chronic disease. Think cirrhosis, chronic hepatitis B.
So those are the main culprits, the key risk factors we look for.
Definitely. Cirrhosis from any cause, really alcohol, fatty liver disease, Hep C is a major player. And chronic hepatitis B infection is another huge one, especially in certain parts of the world. Even without full-blown cirrhosis, Hep B significantly bumps up the risk.
And non-alcoholic fatty liver disease, NAFLD, you mentioned that too. That seems increasingly common.
It really is. With rising rates of obesity and metabolic syndrome, we're seeing a lot more NAFLD, and unfortunately that translates into more HCC down the line. Chronic Hep C and alcohol are still significant contributors too, of course.
So because the liver is often already compromised, our usual TNM staging tumor node metastasis just doesn't cut it.
Precisely. TNM is great for describing the tumor's anatomical spread, size, nodes, distant mets. But it doesn't tell you if the patient's liver can actually handle aggressive treatment.
Right.
You could have a tiny tumor, technically early stage by TNM, but if the liver is severely decompensated, say Child-Pugh class C, then surgery or potent therapies might be completely off the table. The liver's functional reserve is just as critical, if not more so, than the tumor size.
And you also need to factor in the patient's overall condition, right? Their performance status.
Absolutely. Can they tolerate the treatment? Can they carry out daily activities? That's often measured by the ECOG performance status. So the best staging systems for HCC have to weave together all three: tumor burden, liver function, and performance status.
Okay, that makes perfect sense. So let's say we have a high-risk patient, someone with cirrhosis or chronic Hep B, and a suspicious liver lesion pops up on screening. What's the very first step in the workup?
The absolute starting point is high-quality multi-phase imaging. We're usually talking about contrast-enhanced MRI or CT scan.
MRI or CT, okay.
Yeah, and the multi-phase part is key. We need to see how the lesion behaves during different phases of contrast injection, arterial, venous, delayed phases. This helps us spot the characteristic vascular patterns of HCC.
And to make sure everyone's reading these images the same way, there's a specific system, right? LIRADS. Tell us about that.
Yes, LIRADS, the Liver Imaging Reporting and Data System. It's incredibly important. It standardizes how radiologists classify liver lesions in high-risk patients.
So standardized reporting.
Exactly. It avoids ambiguity, makes multidisciplinary team discussions much smoother. LIRADS focuses on key features, especially two major ones for HCC.
Which are?
Arterial phase hyperenhancement, or APHE. That means the lesion lights up really brightly and quickly in the arterial phase. And the second is venous phase washout, where the lesion then loses that contrast relatively quickly in the later phases, appearing darker than the surrounding liver.
APHE and washout. Got it.
Hi.
The classic HCC signature on imaging.
That's the one. And LIRADS uses these features, plus others like size and capsule appearance, to assign a category. It goes from LR1, definitely benign,
Okay.
all the way up to LR5. An LR5 lesion means it's definitely HCC, with about a 95% probability.
Wow, 95%.
Yeah.
So LR5 is basically diagnostic.
That's a critical point. For an LR5 lesion in a high-risk patient, it is considered diagnostic. Typically, you do not need a biopsy to confirm HCC.
That saves the patient an invasive procedure.
Right. It avoids the risks of bleeding or tumor seeding from a biopsy and lets you move straight to treatment planning. There are also intermediate categories like LR3 indeterminate and LR4, probably HCC, which might need follow-up imaging or sometimes a biopsy. And there's LRTR, which means definite tumor in vein.
Okay. And does this LIRADS score connect to anything else, like transplant eligibility?
It does. The LIRADS classification can directly feed into the OPTN system. That's the Organ Procurement and Transplantation Network.
The QTM.
Yeah. OPTN uses specific criteria, often incorporating imaging findings consistent with HCC based on LIRADS, to determine formal eligibility and priority for a liver transplant. It shows how imaging diagnosis links directly to potential curative treatments.
Now, you mentioned pathology earlier, or rather a specific appearance. Not all HCC looks like that classic round enhancing mass, right?
That's a really important clinical pearl. While we often train our eyes to look for that textbook enhancing mass with washout, you absolutely have to be aware of infiltrative HCC.
Infiltrative HCC, how does that look different?
It presents with much more diffuse, indiscrete margins. It doesn't form a nice, neat ball. It kind of spreads out and blends into the liver tissue.
So it's harder to see, harder to measure.
Exactly. It can be much harder to delineate on imaging, sometimes mimicking just background cirrhosis or inflammation. It often lacks those sharp borders we rely on. This pattern might make biopsy necessary, even if the suspicion is high, just to confirm what you're dealing with. Keep infiltrative HCC in your differential.
Good point. Okay, so we have the diagnosis, maybe via LR5 imaging or biopsy. Now we need to stage for treatment. And the go-to system is the Barcelona Clinic Liver Cancer Staging, or BCLC. Why BCLC and not just TNM?
Because, as we discussed, BCLC brilliantly integrates those three key pillars: the tumor factors, size, number, vascular invasion, the liver function, and the patient's overall performance status, like ECOG status.
Right, the three pillars.
Yeah. It gives a much more holistic view and, crucially, directly links the stage to recommended treatment strategies. It's much more clinically useful for guiding therapy in HCC than TNM alone.
Okay, let's walk through the BCLC stages. There are 5, right? Starting with stage 0.
Stage 0 is very early HCC. Think of a single tumor, less than 2 centimeters. The patient has excellent liver function Child-Pugh A and great performance status, ECOG 0.
And the treatment for stage 0.
For these patients, the goal is cure. Resection, surgically removing the tumor, is the primary recommendation if they're a good candidate. This offers the best outcomes.
Okay, straightforward. What about stage A, early HCC?
Stage A is a bit broader. It includes a single tumor or maybe up to 3 nodules, but they all have to be less than 3 centimeters each. Again, patients usually have preserved liver function, Child-Pugh A, and good performance status.
And this is where the Milan criteria come in, right, for transplant?
Exactly. Stage A is where many patients potentially meet the Milan criteria for liver transplant, and you have to know these criteria.
Let's hear them.
Okay, Milan criteria. 1 single tumor less than or equal to 5 centimeters in diameter, or are up to 3 separate tumors, none of which are larger than 3 centimeters, and critically no macrovascular invasion and no extrahepatic spread.
Single tumor, 5 centimeters or less, or up to 3 tumors, each 3 centimeters or less. No vascular invasion, no spread outside the liver. Got it.
Perfect. So, patients meeting Milan are candidates for curative therapies. That could be resection, liver transplant, which removes the tumor and the underlying diseased liver, offering the best long-term cure, or local ablation, like radiofrequency ablation, RFA, or sometimes stereotactic body radiation therapy, SBRT.
You mentioned SBRT there, and earlier you touched on downstaging. This sounds like a really important strategy. Can you explain how that works, especially with radiation?
Downstaging is a fantastic concept. Imagine a patient who almost meets Milan criteria, but maybe they have a single 6-centimeter tumor. Normally, they wouldn't qualify for transplant.
Right, too big.
But using specific protocols like the UCSF downstaging criteria.
Criteria, okay.
Well, we can use locoregional therapy to actively shrink the tumor burden. We treat the tumor, often with TACE or SBRT, aiming to reduce its size or number until the patient does fit within the Milan criteria.
So you treat them to get them eligible for transplant.
Precisely. It turns an ineligible patient into a potential transplant candidate. And SBRT is a really powerful tool for this, delivering high ablative doses. This is often what we mean by bridging therapy with SBRT, bridging them to transplant eligibility and keeping the tumor controlled while they wait. It's proactive, goal-directed therapy.
Very cool. Okay, what about BCLC stage B, intermediate stage?
Stage B is characterized by multinodular disease, multiple tumors, often larger, but still confined to the liver without vascular invasion or spread outside. Liver function is usually still okay, maybe Child-Pugh A or early B, and performance status is good.
And the classic treatment here.
This is the prime indication for TACE, transarterial chemoembolization. It's really considered the standard, the workhorse therapy for BCLC stage B. The goal is typically palliation, controlling the disease within the liver, prolonging survival.
Got it. Then comes stage C, advanced disease. What defines this stage?
Stage C means things have progressed. It's defined either by macrovascular invasion. The tumor has grown into major blood vessels like the portal vein or hepatic veins, or R by extrahepatic spread, meaning the cancer is outside the liver in lymph nodes, lungs, bones, etc.
Even if liver function is still okay.
Yes, patients in stage C might still have Child-Pugh A or B liver function and good performance status, but the extent of the disease means locoregional therapy alone isn't enough.
So what's the treatment focus for stage C?
Systemic therapy.
Yeah.
Treatments that circulate throughout the body to target cancer cells wherever they are. This is where the newer drugs have made a huge impact.
Okay. And the final stage, stage D.
Stage D is terminal disease. This means either the patient has very advanced decompensated liver disease, Child-Pugh C, or their overall health is very poor, ECRG 3 or 4, meaning they're quite debilitated.
And treatment for stage D.
For these patients, aggressive anti-cancer treatment is usually not beneficial and can cause more harm. The focus shifts entirely to best supportive care, managing symptoms, maximizing comfort, ensuring quality of life.
Makes sense. Now, you've mentioned the Child-Pugh score multiple times as being critical for BCLC staging and treatment decisions. Let's break that down. It assesses liver function. What are the components?
Yes, the Child-Pugh score is non-negotiable. You absolutely have to know it. It quantifies liver dysfunction based on 5 parameters. I use the mnemonic A, B, C, D, E to remember them.
A, B, C, D, E. Okay, I like mnemonics. What do they stand for?
A is for albumin low levels mean poor liver synthetic function. B is for bilirubin. High levels mean the liver isn't clearing waste properly. C is for coagulation, measured by the INR. A high INR means impaired production of clotting factors.
Okay, A, B, C.
D is for distension, specifically from ascites fluid buildup in the belly. And E is for encephalopathy, brain dysfunction due to toxin buildup.
Albumin, bilirubin, coagulation, INR, distension, ascites, encephalopathy. Got it. A, B, C, D, E.
Each one gets scored 1, 2, or 3 points based on severity. You add up the points.
And how does the total score translate into classes?
Scores of 5, 6 points put you in Child-Pugh Class A. That's well-compensated liver function. 7, 9 points is Class B, significant functional compromise. And 10, 15 points is Class C, decompensated, end-stage liver disease.
And why is this stratification so vital for treatment decisions?
Because it tells you what the liver can handle. Most aggressive therapies, surgery, transplant, SBRT, potent systemic drugs, are generally reserved for Child-Pugh A patients. Their livers have the reserve to tolerate the stress.
What about Class B?
Child-Pugh B patients often need dose adjustments, less aggressive approaches, or might be excluded from certain trials or treatments. Their liver function is already shaky.
And Class C is generally best supportive care.
Typically, yes. The risks of aggressive therapy in a Child-Pugh C patient usually far outweigh any potential benefits. Their liver is just too fragile. It's a real gatekeeper for treatment eligibility.
That's crystal clear. Okay, let's switch gears to the actual treatment techniques, starting with locoregional therapies for patients with localized HCC who aren't candidates for surgery. What are the main options?
Well, a major player for curative intent in small tumors is radiofrequency ablation, or RFA.
RFA. How does that work?
It uses heat. An electrode probe is inserted directly into the tumor, usually under image guidance like ultrasound or CT. Then, alternating electrical current generates heat, essentially cooking and destroying the tumor tissue.
Sounds effective. What's the sweet spot for RFA, ideal patient?
Ideally, you're looking at tumors less than 3 centimeters in size. And crucially, the tumor should not be right next to a major blood vessel.
Why the location restriction near blood vessels?
That's RFA's main weakness, something called the heat sink effect. Blood flowing through a nearby large vessel rapidly carries away the heat generated by the RFA probe.
Like a radiator cooling it down.
Exactly. It prevents the tissue right next to the vessel from reaching lethal temperatures, so you can get incomplete ablation at the tumor margin closest to the vessel, leading to recurrence there. It's a significant limitation for perovascular tumors.
And that limitation is where SBRT often comes into play, right?
Precisely. Stereotactic body radiation therapy, SBRT, is often a much better option for those tumors snuggled up against blood vessels.
Because radiation isn't affected by blood flow in the same way.
Correct. SBRT delivers highly focused, very high doses of radiation. The dose kills cells regardless of the adjacent blood flow. We use advanced imaging and targeting to conform the dose tightly to the tumor, sparing nearby normal tissues.
What kind of doses are we talking about?
We're talking ablative doses, often something like 30 to 50 gray delivered in just 3 to 5 treatment sessions or fractions. It's a very potent, localized treatment. Of course, managing respiratory motion is critical for accuracy.
We already mentioned SBRT's role in bridging and downstaging for transplant.
Yes, it's a key application. It allows us to treat tumors that might be technically unresectable or unsuitable for RFA, potentially making patients transplant eligible or providing durable local control.
Okay, so RFA and SBRT are often ablative, potentially curative. What about TACE? You called it the workhorse for stage B. Is it curative?
TACE, transarterial chemoembolization, is generally considered palliative, not curative, though it can provide significant benefit. It's the mainstay for BCLC stage B, that intermediate multinodular stage.
How does TACE work? It sounds like a combo therapy.
It is. An interventional radiologist threads a catheter through the arteries into the hepatic artery feeding the tumor. Then they inject two things: tiny particles to block the small blood vessels supplying the tumor, that's the embolization part, causing ischemia.
Starving the tumor.
Right. And they also inject chemotherapy drugs directly into that artery, the chemo part. So you get a double whammy, cutting off blood supply and delivering concentrated chemo locally.
But the local control isn't always perfect.
Often, no. While it can control disease and prolong survival, complete eradication of the treated tumors is less common than with truly ablative methods like RFA or SBRT. Patients might need repeat TACE procedures, and there's often post-embolization syndrome, fever, pain, nausea for a few days after.
Okay. Now there's also TARE. Similar name, similar approach.
Similar delivery approach, yes, transarterial. But TARE stands for transarterial radioembolization. Instead of chemo, it delivers radioactive microspheres.
Radioactive beads.
Tiny beads, usually loaded with yttrium-90 or Y90. They lodge in the tumor's microvasculature and deliver internal radiation directly to the tumor over time.
Yttrium-90, okay. When is TARE typically used?
It's often considered for larger tumors, or sometimes when there's portal vein thrombus, as the radiation might help treat the tumor thrombus itself. It can be an alternative to TACE in some intermediate stage patients, or sometimes used in more advanced settings, though its role there is debated.
And before TARE, there's an important planning step, right, with MAA?
Absolutely critical. Before the actual Y90 treatment, patients undergo a mapping angiogram using technetium 99-meter labeled macroaggregated albumin, or MAA.
MAA scan, what does that tell you?
Two main things. First, it estimates the lung shunt fraction, how much of the injected substance bypasses the liver and goes straight to the lungs. Too high a shunt means too much radiation dose to the lungs, which is dangerous. Second, it helps identify any arteries feeding other organs, like the stomach or bowel, that might arise from the target vessel. Those need to be blocked or coiled to prevent the radioactive spheres from going to the wrong place.
So safety checks are paramount.
Extremely. Non-target embolization can cause serious complications.
Now, can TARE ever be used with curative intent, like SBRT? You mentioned radiation segmentectomy.
Yes, that's an advanced application. Radiation segmentectomy uses TARE not just to control, but to ablate a tumor, typically a solitary one. The idea is to deliver a super high radiation dose, aiming for maybe over 400 gray to the volume being perfused by those Y90 spheres.
400 gray, that's massive.
It is. It's aiming for complete tumor necrosis, essentially trying to achieve a similar outcome to surgical resection or SBRT, but using intra-arterial radiation. It requires very careful planning and patient selection.
Fascinating. Okay, let's move on to systemic therapy now. This is for the advanced cases, BCLC stage C, where the cancer has spread or invaded vessels. You said this area has changed a lot.
Dramatically. For over a decade, the main option was sorafenib, a multi-kinase inhibitor. And honestly, the benefit was quite modest. The field felt pretty stagnant.
But not anymore.
Not anymore. The arrival of immunotherapy, particularly combination therapies, has completely revolutionized first-line treatment for advanced HCC.
And the key trial here that everyone needs to know is IMBRAVE 150.
IMBRAVE 150, absolutely pivotal. This trial compared the old standard, sorafenib, head-to-head against a combination of two drugs.
What was the combination?
It was atezolizumab, which is an immunotherapy drug, a PD-L1 inhibitor,
Atezolizumab, PBL1. Okay.
plus bevacizumab, which is an anti-VEGF drug. It targets blood vessel formation.
Bevacizumab, anti-VEGF.
Got it.
Atezolizumab plus bevacizumab, and the results.
The combination was clearly superior. It significantly improved both overall survival and progression-free survival compared to sorafenib.
Do you remember the key numbers? Like 1-year survival?
Yeah, the 1-year overall survival was around 67% with the atezolizumab-bevacizumab combo versus about 55% with sorafenib. And the median overall survival pushed past 19 months with the combination, which was a really meaningful improvement.
Wow, that's a significant difference. So this combo is now the standard of care.
For first-line treatment of unresectable HCC in patients with good liver function, specifically Child-Pugh, yes, atezolizumab plus bevacizumab is the undisputed NCCN Category 1 preferred regimen. It completely changed practice overnight.
Category 1, preferred. That's clear. Now, there's a really important safety consideration with this combination, specifically because of the bevacizumab component. What do residents absolutely need to remember before starting this treatment?
This is critical, yes. Bevacizumab, being anti-VEGF, increases the risk of bleeding. And in patients with cirrhosis and portal hypertension, the biggest bleeding risk is often from esophageal varices, those enlarged veins in the esophagus.
Which can cause catastrophic bleeding if they rupture.
Exactly. So before starting atezolizumab bevacizumab, it is mandatory to perform an upper endoscopy, an EGD.
EGD first.
Yes, to screen for varices. If high-risk varices are found, they must be treated, usually with banding, before the patient starts the atezo-bev combination. Failure to do this significantly increases the risk of a major, potentially fatal variceal bleed. It's a huge safety point and a common board question.
Screen and treat varices with EGD before starting atezo-bev. Got it. What if a patient can't get bevacizumab or has Child-Pugh B liver function?
Good question. If bevacizumab is contraindicated, or for some Child-Pugh B patients, other first-line options like lenvatinib, another tyrosine kinase inhibitor, might be used. And there are other combinations emerging too, like durvalumab plus tremelimumab. But atezo-bev remains the most established Category 1 preference for Child-Pugh A.
Okay. Now, what about TARE in this advanced setting? We talked about TARE for localized disease, but were there trials looking at it versus systemic therapy for advanced HCC?
Yes, and this is important context. Two major trials, SARAH and SIRV-NIB, directly compared TARE using Y90 microspheres against sorafenib in patients with advanced HCC, many with portal vein invasion.
SARH and SIRV-NIB, and what did they find?
Both trials were negative. They showed that TARE did not improve overall survival compared to sorafenib in that advanced setting.
So TARE is not a standard first-line systemic option for advanced HCC.
Correct. Based on SARH and SIRV-NIB, TARE's role is primarily in the locoregional setting for intermediate stage disease or potentially for downstaging bridging or radiation segmentectomy in select cases. It's generally not used as the primary systemic therapy for BCLC stage C. Systemic therapy, like atezo-bev, remains the standard there.
That clarifies its position. And briefly, was there a trial supporting SBRT's role maybe for tougher cases?
Yes, RTOG 1112 provided good evidence supporting the use of SBRT for HCC, including for larger tumors and those with vascular invasion. It showed excellent local control rates and helped solidify SBRT as a strong option, particularly when surgery or other local therapies aren't feasible.
Okay, RTOG 1112 supporting SBRT. Great. Let's shift into our board blitz section now. I'll give you a scenario. You tell me the answer and the reasoning. Ready for case 1?
Let's do it.
All right. Based strictly on the Milan criteria, which one of the following would be a contraindication for liver transplant? A single tumor measuring 4.5 centimeters. B, tumor involving the portal vein. C, 2 tumors, one is 2.5 centimeters, the other is 1.0 centimeters. 3 tumors, each measuring 2.5 centimeters.
Okay, thinking through Milan, single tumor up to 5 centimeters is okay, so A is in. Up to 3 tumors, each up to 3 centimeters is okay, so C and D are in. Milan explicitly excludes macrovascular invasion. Portal vein involvement is macrovascular invasion, so the answer has to be B.
Exactly right. Tumor involving the portal vein is macrovascular invasion and absolute no-go under Milan criteria.
Right.
Options A, C, and D all fit perfectly within the size and number limits. Great breakdown. Case 2.
Okay.
You have a 70-year-old man with unresectable HCC. He has invasion into the main portal vein. His liver function is good, Child-Pugh A. What's the standard of care for first-line treatment? A, sorafenib monotherapy. B, radioembolization with Y90, TARE. C, atezolizumab and bevacizumab, D, TACE.
Okay, unresectable HCC with main portal vein invasion that immediately tells me BCLC stage C advanced disease. Liver function is Child-Pugh A. So for first-line systemic therapy in stage C, Child-Pugh A, the standard is atezolizumab and bevacizumab based on IMBRA VE 150. Sorafenib is older standard. TARE was shown non-superior in SARH, SIRVE, and IB, and TACE is for stage B. So it's C.
Perfect reasoning. C, atezolizumab and bevacizumab is the correct answer, established by IMBRA VE 150 for this exact scenario. Okay, last one, case 3.
Right.
For which of these scenarios would liver SBRT be a recommended treatment over other local therapies? A, resectable extrahepatic cholangiocarcinoma. B, a 7-centimeter HCC tumor invading the portal vein. Child-Pugh A liver. C, metastatic rectal cancer.
Yeah.
Solitary 5-centimeter liver met invading the duodenum. D, metastatic colorectal cancer, 3 small liver mets plus lung mets.
Okay, let's break these down. A, resectable cholangio. No, surgery is primary. C, liver met invading duodenum. That's a major contraindication for SBRT due to bowel toxicity risk. D, multiple liver mets plus lung mets. That's widespread metastatic disease needing systemic therapy primarily, not just local SBRT to the liver. So that leaves B, a large 7-centimeter HCC invading the portal vein in a Child-Pugh A patient. This is actually a great indication for SBRT. It can handle large tumors, isn't limited by vascular invasion like RFA, and the patient's liver function can tolerate it. RTOG 1112 supports this too. So B is the best answer.
Excellent analysis. B is indeed the correct scenario where SBRT would be strongly considered, often preferred, given the size, vascular invasion, and good liver function. You nailed those.
Practice makes perfect, right?
Absolutely. So let's just quickly recap the main takeaways from our discussion today on the HCC Management Toolkit.
Okay. First, remember the core frameworks. BCLC staging is key because it integrates tumor, liver function via Child-Pugh, and performance status. And you absolutely need to know the Child-Pugh components A, B, C, D, E.
Right. And for local regional therapies, know their strengths and weaknesses. RFA is great for small tumors, but watch out for the heat sink effect near vessels.
Yep. TACE is the palliative workhorse for intermediate multinodular disease, stage B. And SBRT is a fantastic option for perovascular tumors, larger tumors, and critically for bridging or downstaging patients towards transplant.
And remember, the TARE trials, SARH and SIRVE and IB, showed it wasn't superior to sorafenib as a first-line approach for advanced disease.
Which brings us to the current standard for first-line systemic therapy in advanced, Child-Pugh AHCC, atezolizumab plus bevacizumab, thanks to the IMBRA VE 150 trial. And don't forget that mandatory pre-treatment EGD to check for varices.
Fantastic summary. This really covers the essentials residents need to know about staging, IR, and systemic therapy for HCC. Keep reviewing these concepts. They form the bedrock of modern management.
And as you move forward, think about how these pieces fit together even better. We're seeing more research combining systemic therapies with local regional treatments like SBRT. The future is likely in finding those optimal combinations and sequences to push outcomes even further for patients facing this challenging disease. How can you best integrate these tools for your future patients?
A great thought to end on. For everyone listening, you can find complete practice oral boards and detailed show notes covering everything we discussed today over at radoncSmartLearn.com. That's radoncSmartLearn.com.
Make sure to check it out.
And please subscribe to Rad Onc Smart Review so you don't miss our next session. We'll be doing HCC Part 2, focusing specifically on an SBRT workshop, really getting into the practical details. Thanks so much for tuning in today.